So, good morning, everyone. This is episode 4 of Prostate Cancer and Prostate Disease podcast. I'm here with Dr. Ditonno, directly from Chicago. So, we will explore his recent article on novel non-MRI imaging techniques. So, he will guide us a little bit through his review paper. So, this is the article we are talking about. Okay, so we'll ask to present yourself, Dr. Ditonno, a little bit your duties, what you do in Chicago, and so we can get to know you better.
Hi, Riccardo. Hello, everyone. Thank you for the invitation and this opportunity. I'm Francesco Ditonno, as you said. Currently, I'm a clinical research fellow at Rush Urology in Chicago, United States. And my primary areas of interest are uro-oncology, in particular prostate cancer, and minimal invasive therapeutic techniques. This is why basically we decided to conduct this narrative review about non-MRI imaging techniques for diagnosis of prostate cancer.
Okay, very good. So what was the input for the review actually?
So basically the clinical question for this review stemmed from the growing interest in non-MRI imaging technologies in the landscape of prostate cancer. We aimed to investigate the potential advantages that these techniques may add to the PCA diagnostic pathway. We wanted to explore their accuracy in the study of the gland and if they may overcome some of the limitations of multiparametric MRI.
Okay, very good. So let's go a little bit more inside your article. So what can you tell me about these different imaging techniques? Meaning, there are not, some of them are known by all urologists, some of them are not. So because some of our readers may not be keen on these techniques, can you give a little bit an overview on the characteristics of these imaging techniques?
Yes, of course. So the diagnostic techniques we analyzed are really diverse and vary between each other. So we can basically categorize them into two categories. So ultrasound-based technologies and nuclear medicine-based technologies. The micro ultrasound uses a probe, a standard probe, but it has an higher resolution compared to the standard traditional ultrasound. Instead, the contrast-enhanced ultrasound uses also the injection of a contrast medium to enhance, highlight the areas of interest. Multiparametric ultrasound combines a lot of different techniques. So the final result is a combination, as I said, of the different approaches. And then we have the elastography, which can be divided into strain and shear wave elastography, which are two different techniques, mainly based on the same rationale, on the same technology. For what concerns nuclear medicine, we basically focused on PSMA, which is the newest radio tracer available, trying to include all the different molecules that are used as radio tracers across the literature.
So because probably elastography is the less known by general urologists, but is it similar to the one the gastroenterologists use for the liver?
Yeah, basically yes. So it is based on the strain of the tissue. So the ultrasound goes through the tissue, and based on its resistance on the passage of the ultrasound, it gives back the result. That's how it works, basically.
Okay, and what do you think there, because their position may be in when compared to MRI actually, what are their position right now and the ones you see in the future?
So this is I think the most significant question. of all on this topic. First of all, I believe that as of now, none of these methods could replace MRI, multiparametric MRI. We know that this adds well-established advantages to the diagnostic pathway of PCA in terms of diagnostic performance and also cost effectiveness. And this is, as I said, well known. Meanwhile, some of these techniques, for example, like elastography, as we were saying, they've been around for a while. As you mentioned, it's used also by GIs. So, but it has intrinsic limitations, and these have hampered their widespread use. So currently, it's too early to compare it to multiparametric MRI.
And what do you think, what do you think, which of these techniques you believe will succeed or have the best odds to succeed? So in your opinion.
So I think that the most interesting are microultrasound and multiparametric ultrasound because they have a strong technical justification. But above all, microultrasound, I think that could be the standout among all these techniques because it retains the advantages of a US-based technique. So it offers the potential for a real-time in-office diagnosis. And it uses a familiar tool for urologists, which is the ultrasound probe. And nowadays, it is the technology with the most convincing evidence so far. So because it has data from prospective trials, and also there is a scoring result that at least they tried to standardize it, which is called the Primus score. I think that it has a downside, which is the cost, and maybe as we go on with its discovery, maybe its cost effectiveness may be realized through maybe a reduced outpatient visits, or maybe the elimination of the need for dedicated machine environments. Even though, like a dedicated cost analysis is lacking, and to draw a conclusion on this matter, it is necessary to go through a specific cost analysis of this technique.
So, as you said, for the time being, micro ultrasound probably doesn't still have the characteristic to replace MRI, but in some of the studies, actually, it performs almost equal. But what are the main limitations, actually, of these new techniques? What do you believe that why are they struggling to go through the diagnostic pathway?
So, besides what I previously mentioned, so the cost effectiveness, I think that another major limitation is the lack of reproducibility and standardization, because there's an absence of validation studies for the proposed diagnostic score, the Primus. And I think that this is really highlighted in our review. I think that one of the main concepts, the take-home messages of our review is this, so that there is a lack of standardization across these techniques. And also the lack of a direct comparison, and I think we're going to talk about it later, but the lack of a direct comparison between the micro ultrasound, but all of the techniques included in the review, and the standard of care, and also between each other would be really interesting. And I think that this is a pivotal step to implement these techniques in our daily practice.
So talking about that, do you really believe that the Optimum trial, which is actually a direct comparison between, for the ones that do not know and are listening to our podcast, is actually a direct comparison between the micro ultrasound and the MRI, it's a randomized trial, so it's been struggling a little bit because they had some problems with recruitment, but we should have the results of these trials very soon. So do you believe that it's really the competitor? Because the ones that are supporting micro ultrasound, they just want to bring back radiology to urologists as it was in the past. So what is your opinion on this important debate and important war between urologists and radiologists?
Yeah, I think that the Optimum trial has a strong rationale, and for sure it will address some open questions in this field. And I think that researchers are exploring really interesting endpoints beside the primary endpoint, which is the clinically significant PCA detection, which is quite obvious. I think that another interesting endpoint, secondary endpoint, is the comparison between diffusion techniques. And that would be really game changing, I think, because we will understand if micro ultrasound has to be used in addition to multiparametric MRI, or it can replace it. So that is a good point to raise. And also the cost analysis will be interesting. As we said, this is an important part of the the implementation, the approval of a novel technique. So these are the main messages. As you said, they're experiencing some trouble with the accrual. And of course, I think that its statistical power will need verification once the results are available. And as this is a long-standing debate about RCT, so their applicability and generalizability that may be confined to referral centers, which is just a fraction of the broader urological landscape. So we'll see what happens with final results.
What I wanted to, in this slide, which I think it's very important for the people to see, but it's really evident, is how ultrasound in general, and in this case micro ultrasound, is actually operator dependent, because now here we have very different accuracy characteristics and discrimination characteristics for different studies performed by trained urologists to use micro ultrasound. But I don't know if you agree with me, but I think that with the very fast advance of artificial intelligence, I think that probably we will see an automatization of the identification of the lesions in the micro ultrasound, because you just need to do a good scan to perform a good exam with a good visibility and a good preparation of the patient, maybe. So, and probably we will end up having a more standard report, but that will work too for MRI, which for in this case, we have a little bit more literature, and all the literature says that actually radiologists helped by AI are better than radiologists who are not helped by AI. I would like to move on a more interesting topic, meaning that this is a very hot topic, because the nuclear medicine is really getting into our clinical practice, into our everyday clinical practice. And as we started with PSMA PET for recurrent prostate cancer, now we're beginning to have the first experiences in prostate cancer diagnosis. But as we see in this table, it is evident that the discrimination abilities are very good. But I would like to, very recently, they published from Australia a protocol to propose that patients with PSMA PET negative shouldn't go to prostate biopsy. So I wanted to know, what is your opinion, given the fact that you really went into the literature of such a topic?
So I think that PSMA PET is an appealing technique, as you said, as we are showing in this slide in the table we published in our review. I hope it replicates the diagnostic setting. In the diagnostic setting, the promising results that were achieved with the nodal staging. Also because it would eliminate the need for a separate diagnosis and staging procedure, which would be really time saving. And if this happens with equal or improved results, it would be a great achieve. Also because when reviewing the literature, we found out that there's a strong direct relationship between lesions avidity of radio tracer and histopathologic and prognostic features. The downside is as we said, for previous techniques, the lack of standardization. So there is a great variability in terms of reporting, interpretation of the results. And also in terms of radio tracers and access to this technology. I think this is the access to this technology is the main drawback. So I think that it's early to consider to replace histologically proven diagnosis based on biopsy, also because biopsy is well-established and relatively harmless procedure, if we can say this. So, but results are interesting, so we'll have to explore a little bit more with prospective studies to see more convincing and more convincing results.
And do you believe, because one of what is interesting of the design of the study, of the Australian study, is the fact that probably they feel that a negative PSMA PET probably is not seeing significant cancers. So as we know, we still have a very big problem in diagnosing non-significant cancers. So do you believe that this technique may be game-changing in the future, especially, let's say, for those patients, young patients, that you may not want to identify those non-clinical significant cancers?
Yeah, I think that as long as its negative predictive value is proven, is confirmed, I think that this would be really a game changer, because we could spare diagnosis, stress, and even treatment to some of these patients who want to be treated just because they know they have cancer. I think that nowadays the fact we have to stress is the fact that when counseling patients is the fact that harboring a Gleason 6 tumor can be treated like just surveilling it. So that active surveillance is a treatment just as radical prostatectomy. I think this is a key message for our patients. If PSMA PET confirms this benefit, also this advantage, I think that this is a great thing to keep in mind when thinking about if to diagnose the prostate cancer.
Okay, and what do you think about screening programs? Do you think that any of these techniques may have a role? Because you went through the literature for prostate cancer diagnosis, but maybe you went through some studies, or what can you tell me about these techniques in a different setting?
So my idea when talking about screening is in line with what we were previously saying. So I think that clinicians may consider adopting these techniques just for patients with clinical suspicion of PCA. So it's exactly what we do with MRI. The real advantage of these techniques would be that they could be performed in an in-office setting. So they may enhance patient counseling, also the decision-making progress. since like clinicians may be able to quantify the risk of PCA immediately, readily, and they can discuss it with the patient instead of just waiting for MRI results, then have another appointment, another visit, another encounter with the patient. So it would also reduce patients' procedure-related stress, if it can be defined like this. And maybe also they could be more accessible and well tolerated from the patient perspective compared to MP-MRI. Once they're standardized, I think that this could be an additional advantage that may be considered.
Well, it depends on the patient, meaning that sometimes
Yeah.
it depends on the tolerability of the patients, because maybe probably, I mean, I performed micro ultrasound, and it's not like performing a normal transrectal ultrasound, meaning that unfortunately, I mean, we are used, and as the guidelines say, we are used to perform a transrectal ultrasound just to measure the prostate. So differently, when you go through a transrectal ultrasound with micro ultrasound, you have to go through the whole prostate to be very slow to identify those difficult to identify patterns, because you have to train your eye. So I believe that somehow, I don't know, in my opinion, what it's really interesting about your review is that maybe we will see with or I hope we will see in the future, because these techniques, by your paper, it is evident that they have a role in prostate cancer diagnosis, meaning that they have the characteristics, they've been proven more or less effective and with different characteristics. And for what we have seen, it actually will probably not substitute MRI, and meaning that the invasiveness or the availability of a micro ultrasound, if it's widely available, will follow or will solve some negative MRI cases, or may be performed to analyze patients before MRI. And I probably believe that for a problem of costs, PSMA will be very difficult to put it in an early phase. So if I imagine writing or reading your review, I imagined the techniques step by step, meaning that I could start with a micro ultrasound, then go for an MRI if I see something, because actually even some studies have shown that having both techniques may even improve our detection rate of
of course.
So, and then in those cases, particularly with the help of calculators or genetic testing, where we really want to have a good idea of staging with PSMA, we can use PSMA, because the only problem is that PSMA may be very sensitive somehow. So in some, we could have some false positive cases that may actually complicate our clinical scenario, particularly because since we don't have PSMA PET for staging, then it is a little bit of a countersense right now to put it in the diagnostic phase.
In the diagnostic step,
But I really believe that it won't be just few years that we will have a clearer scenario. So I would like to know, in your opinion, what are the future perspectives for this area of research? And if you think that PSA era may be almost over, and if you think there are some gaps in the literature, and what you really believe is missing in the literature.
So I think that, as we said, so these techniques represent an interesting field, especially in clinical research. They're really appealing and expanding. As you said, they have a role in PCA diagnosis, so their integration into the standard diagnostic pathway could have several advantages, and also overcome some of the limitations associated with multiparametric MRI. So I think that what is lacking, what is missing in the current literature is an assessment of their limitations. So this should be done through technological advancement, and also obviously through future research efforts. So to provide unbiased direct comparisons between gold standard and these new diagnostic tools. And as we know, as we said, a lot of trials are underway. So the Optimum trial for ultrasound-based technologies, and also the Prospect BX for PSMA PET. So hopefully these trials will provide answers to the open issues that we talked about during our conversation.
You know, what I really think is could be game changing is to have the same patient having different diagnostic modalities. Unfortunately, the literature often designs randomized clinical trial because they represent the highest level of evidence. But I really believe that, for instance, in this case, especially for the prostate, because if you think some of these technologies, especially ultrasound, is severely limited by the presence of calcifications, or MRI is limited by the presence of previous biopsies. So I think that performing the same different techniques on the same patient and see really what they are able to see or not, ideally having patients with radical prostatectomy after. So to really see, because actually nowadays we're performing at least 16 to 20 biopsies to every patient because we cannot avoid standard biopsies. So very often when you're reading these papers, it's very difficult to understand if they're talking about detection rate, meaning only the target zone, or detection rate of clinical significant cancer overall.
The whole gland. Yeah,
so
the whole gland.
It's very tricky to go through the literature. And when you go through the reviews which perform meta-analysis, you often find that they just mix different
endpoints.
Yeah, different settings, different types of fusion, because the other big area of debate is the type of fusion. So cognitive versus,
of course,
inborn versus elastography, meaning that the needle is adjusted by artificial intelligence technology. I really believe that it's an area of research that has exploded. Like if you go through the literature of the last year, biopsies are all over the place. So I really think that your review adds important data, and especially what I think it's different is that you really introduce different modalities such as elastography that are not really well known, and also multiparametric ultrasound, which is not very used, or contrast enhanced ultrasound, which is not very known by urologists. So I think that we can invite all the ones that will hear us to read your nice review. And I think that we have done a nice trip through your manuscript. So I give you the word to conclude, and this interesting podcast of the first issue of Prostate Cancer Prostate Disease of 2024.
Yeah, thank you, Ricardo. Thank you very much. Yeah, I totally agree with you. So the matter is really hot, a really hot topic nowadays, and we'll see what happens with all these prospective trials, which will provide results really soon. hopefully. As you said, we wanted to give a comprehensive overview of every technique available, being completely clear, plain on their downsides, their limitations, and also, of course, their advantages. I think that multiparametric MRI, as we know it, is obviously still the gold standard, but all these techniques hold the potential to become valid alternatives to this approach. And so their integration into the diagnostic pathway will be for sure a thing to talk about in the coming days.
So I really thank you. It was a fantastic.
Thank you very much. Thank you very much.
And I really thank you for your time and for this nice trip through your article.
Thank you. Thank you.